This is the first video for labor and delivery and lactation. Similar to previous packets, you can see the objectives and the supplemental readings that are posted on UB-Learns. As in the past, the testable material includes this workbook and any additional starred readings that are listed in the instructions on UB-Learns. The other readings are there for your reference only. We talked about in pregnancy that most gestations last for about 40 weeks, which is just over 9 months and actually closer to 10 months of time in some cases. So for labor and delivery, this is either occurring spontaneously or can occur after cervical ripening and labor induction that is given as a result of medications. So when a woman goes into labor, she may or may not have her water break. So the fetus is enclosed within the amniotic sac. When the water breaks, that means that this sac is bursting. And this is required in order, not in all cases, but in most cases, in order for the fetus to descend much further onto the cervix. So when we talk about labor and delivery, usually the readiness for delivery is graded based on a number of different factors. Some of those include how far the baby has descended. So that occurs more once the water has broken because the cushion that is pushing the head up of fluid is released, and that's the breaking of waters. The cervix, the amount of effacement is measured, and that's how thin the cervix has become. So it's thickened usually during pregnancy, and as labor becomes more imminent, this becomes more thin, so that percentage of effacement is measured. So a higher percentage is usually considered closer to labor. And then how much the cervix is dilated is also measured in terms of centimeters. Up to 10 centimeters is considered the largest, and that's when usually the final stage of labor is occurring and the baby can be passed through the cervix and birth canal. So either the woman's waters will break on their own, or contractions will begin to occur and then the water will break, or the water can be broken manually by a physician or midwife. So only 10% of the time do waters actually break on their own. The rest of the time, either the labor is induced or just contractions occur and then the waters are broken thereafter. If a woman does not go into labor, this could be either because she is past 40 weeks gestation, so 41 or up to a max usually of 42 weeks gestation, or if she has a medical condition that requires induction, medications may be given in order to induce either cervical ripening, so that's the effacement and dilation, or labor contractions. There are mainly two types of medications that are given, either prostaglandin analogs, so E2 or E1 prostaglandins are given, and these are usually given for more cervical ripening. So you can see at the arrow that prostaglandins will stimulate contractions. And then oxytocin is usually the other agent that is most often given, and this simulates natural oxytocin that is released that causes uterine contractions and release of the placenta. These analogs are usually given more towards, the E2 analogs are given more as a prep for induction of labor with oxytocin. So for example, a dinoprostone vaginal insert called Cervidil may be given if a woman's going in for an induction. She might get it the night before in order to prepare the cervix for delivery. And then oxytocin started the next morning once you have a favorable cervix for delivery. Misoprostol, it can be given for cervical ripening and labor induction, but more often oxytocin is the most commonly used agent. Labor can also be induced non-pharmacologically, so this could include something called a balloon or a hydroscopic dilator. These agents go into the cervix and slowly increase in size in order to dilate and create, again, a more favorable cervix for delivery. They are considered as effective as pharmacologic therapy. They're often considered very uncomfortable by the woman. But another advantage is that they don't overstimulate the uterus with contractions because they're considered more of like a natural way for induction. Pharmacologic agents are listed there. They can be combined with those mechanical methods, but they have their own side effects that they go along with. The prostaglandin analogs are more difficult to reverse in cases of adverse effects because they have a longer duration of action. Oxytocin is given as an infusion, so it has a very short half-life. It has to be given continuously as a drip. So this is both an advantage and disadvantage in that if adverse events occur, it can be quickly turned off, but it has to be slowly increased and continued and given continuously in order to be effective. During delivery, the woman may elect to have some type of labor analgesia. This could include non-pharmacologic methods such as massage, water, like warm water or shower, acupuncture, relaxation, or hypnotherapy. And these have varying levels of reported effectiveness. And certainly women can combine these with pharmacologic methods or combine different non-pharmacologic methods. The pharmacologic methods are varied. The most common is epidural anesthesia, but we'll talk about the different types. So parenteral is systemic analgesia. This would be an opioid that is given as an IV or IM, and it has variable levels of pain relief during labor and delivery. It has maternal side effects related to opioid administration, and because of the way that it is given, because it is given into maternal circulation, it will transfer across the placenta and into the fetal circulation, and then may have these effects such as respiratory depression, decreased muscle tone, a difficult time of the infant for suckling, for breastfeeding, and other effects. This is usually not preferred, although some patients experience a greater level of pain relief with this method. An epidural or spinal analgesia or a regional block is much more common. Basically, what this involves is the placement of a catheter into the epidural space. So the epidural space, I'll just scroll down to an image that I have for you. There it is. So the epidural space is right here. Here's the spinal cord. The dura separates the epidural space from the spinal cord, and the epidural anesthesia goes right into this epidural space. So it's not going into the maternal blood circulation. It's just basically bathing the nerves with some type of analgesia. It could be an opioid. It could be combined with an anesthetic, and those are listed there. It has very minor maternal adverse effects. Sometimes it's associated with some symptoms after it wears off, such as pruritus, urinary retention, because the entire bottom half of the body has anesthesia, shivering, and if it had a poor placement, it could have those same opioid side effects. Spinal anesthesia is a slightly different type of injection. This is only administered about 1 hour prior to expected delivery, is more common around a C-section, and was also more common before epidurals became commonplace. So many of our parents would say that a spinal analgesia or a spinal type of regional analgesia was what they received, and that they could only get it for the 1 hour prior to birth. Nitrous oxide is used very commonly in other countries and used to be used more commonly in the United States. It is gaining favor as an inhaled anesthetic agent. It's given via a face mask and can either be given as the sole labor analgesia, or if the woman has elected to go a non-pharmacologic route, it could be given if a laceration occurs during birth that requires some analgesia. It's usually considered less effective, and although there are limited contraindications, patients can control the effect, and as soon as the mask is removed, it can quickly terminate if there are any side effects. Like I said, it's less readily available in the US, and this might be, if you were in the UK, for example, much more common. The final form is general anesthesia. This is either used for vaginal or cesarean delivery and usually only in emergency situations. So this is when the mom would basically be knocked out, if you will, or if the other methods have failed and they need to put the mom under quickly in order to get the infant out. This would include standard risks associated with general anesthesia administration, and women would have to sign a consent. Following delivery of the placenta, lactation can occur relatively quickly, and we'll talk about the different forms of lactation. So for the infant, for feeding, I always preface this by saying that although lactation is what is currently recommended by the CDC and major organizations as the most complete form of nutrition, there are several situations in women that are unable to exclusively breastfeed their infants due to a variety of different reasons related to either production, physical issues, what have you. But the biggest thing is to remember that fed is best. So however the infant receives an adequate amount of nutrition is the best form, although breastfeeding is considered the current recommended form of nutrition for infants. Exclusive breastfeeding, so that's no formula, is recommended for the first 6 months of life, and then that's about the time when table foods or complementary foods are introduced slowly and then can be used in combination with those for the first 12 months. So after that time point, breastfeeding should be continued as long as mutually desired by both mother and baby. So there's some statistics there. So less than 50% of infants are exclusively breastfed through 3 months of life, and only 25% are exclusively breastfed through 6 months. So this should say a little bit about the difficulty of continuing exclusive breastfeeding, especially with women that go back to work. In order to provide exclusive breast milk to their infant, they'll have to use a breast pump in order to store milk and provide it to the caregivers. There's a number of reasons why patients may or may not choose to breastfeed due to either lack of experience, not enough opportunities to communicate with breastfeeding mothers or breastfeeding lactational specialists about how to do this, a lack of up-to-date instructions, hospital practices that make it hard to get started with successful breastfeeding, although this is less common now as many labor and delivery floors have lactational specialists that come see you after you've delivered, help you with placement of the infant so that nipple injuries do not occur and that the infant is able to suckle at an appropriate rate. There's also a stigma associated with breastfeeding in the workplace or in public areas, and a large movement to normalize breastfeeding and make it more commonplace. It's important to note that there is legislation that protects breastfeeding women and allows them in order to either express milk or breastfeed if they so choose. So employers are required to provide a reasonable break time for employees to express breast milk for 1 year after the child's birth, or as long as the employee needs to express breast milk. And it can't be in just some private area like a bathroom. It has to be in another shielded area, free from intrusion from other coworkers or the public. States may also have their own specific regulations, which you can review at the link below.